And in fact, the 60 days, 35% in the ECMO patients and 46 patients, the control group, died, but the difference was not significantly different. Crossover to ECMO occurred 6 plus or minus 10 days after randomization in the 28% of the patients, the control group. And the 57% of them died. So the number of patients that were crossed over had a mortality rate that was dramatically higher than the mortality rate of the control group itself. Now, the frequency of complications was not significantly different, except, and this is expected, for bleeding and anticoagulation therapy-related issue. But that's what you expect. I mean, they were almost committing suicide, but they were saved by this editor. Jeff Drazen is a pulmonologist, intensivist, and by the way, is the chief editor of the New England Journal of Medicine. And he wrote this editorial focusing on the role of Data and Safety Monitoring Board, because the study was interrupted earlier because of a decision of the Data and Safety Monitoring Board. Now, you know that any randomized control trial has a sort of lifeguard, that is the Data and Safety Monitoring Board, that says, okay, keep going. Oh, no, you cannot go. You have to stop because we believe it's too dangerous. And there is nothing you can do about it. And the study was stopped earlier because of the decision of the editor of the Data and Safety Monitoring Board. Now, they, in their analysis, they tried to reanalyze the data and the investigators, and tried to take into consideration some of the elements that I presented to you before. For example, the crossover. And I mean, they play with the data. I mean, most of these studies have more statistics than patients. And by doing so, they were actually able to show that if you took into consideration the crossover, the difference between ECMO and control was significant. But still, the paper is published in the New England Journal of Medicine as negative, because he wanted like this. He's the editor. These are the rules of the game. And I found a little bit schizophrenic the fact that Jeff Drazen, now I can confess, I was one of the reviewers. And I said, this cannot be sold as a negative trial. This should be sold as a wrong trial, because the study design is wrong, but the conclusion is not negative. We don't know yet, because the design is wrong. And he said, no way. The study has to be published as a negative trial. And then, 1 week later, he concluded, these analyses all point out to the same conclusion. ECMO probably has some benefit in this context, which is another example of schizophrenia. Now, I believe that study is not negative, is not positive. That trial is wrong. And we are doing wrong studies in critical care medicine. We should be smarter. We should use these designs that comes from the cardiologists, for example, using adaptive design, Bayesian methodology, pragmatic versus personalized, combined endpoints, and so on. But I mean, we have to be smarter in order to deal with such complex issue. Thank you very much. I have to switch to the other. Okay. Extracorporeal CO2 removal. 4 minutes. Oh. Okay. Now, you have seen this slide, so I can go on. Now, the difference between ECMO and ECHO is that why ECMO, because of the range of flow and because of the size of the oxygenator, is able to deal with both the function, the gas exchange function of the lung, CO2 clearance and oxygenation. Partial extracorporeal support, because of the blood flow, is able only to deal with CO2 removal, doesn't do anything on oxygenation. And I will discuss with you briefly the use of this technology in 3 different areas. Again, ARDS. What's the reason for considering partial extracorporeal support in ARDS? I mean, this is the relationship between plateau pressure and mortality. The higher the plateau pressure, the higher the mortality. The lower the plateau pressure, the lower the mortality. This is where we are. With a tidal volume, with a plateau pressure of about 30 and a tidal volume of 6, we obtain a mortality rate in the range of 40. Now, it would make sense to move down and get a plateau pressure around 20, 25, you obtain a mortality rate of 30%. Now, in theory, if this is true, we can go even more down, eliminating mechanical ventilation and using full ECMO. But, you know, the story is maybe a little bit more complicated than a linear relationship. And to verify this hypothesis, we have a number of studies. Now, I don't have the time to bring you through all these studies. There is even a small randomized control trial that tested this hypothesis. But we don't know if it's safe, and we don't know if it's feasible everywhere, because all these studies were run in a restricted number of sites. So a few years ago, the European Society of Intensive Care Medicine decided to run this preliminary study, the Supernova Trial. What we wanted to do was to assess feasibility and safety of a super protective ventilatory strategy supported by partial extracorporeal support. The outcome was feasibility, to see if it was possible to obtain the super protective ventilatory strategy, so a tidal volume of 4 and a plateau pressure of 25, avoiding respiratory acidosis by using partial extracorporeal support. The secondary outcome was safety. So essentially we went in 3 steps down from 6 to 4, adjusting PEEP to maintain a plateau pressure around 25. The super protective ventilatory strategy, and using 3 devices for partial extracorporeal support. A so-called low-performance device, a blood flow of half a liter, or high-performance device, 2 devices that were able to provide a liter of blood flow. And we look also for safety in terms of frequency of adverse events. Now, we included 95 patients, and as I said, 1/3 of the patients was treated with a device able to provide a flow not higher than half a liter, and 2/3 of the patients were treated with devices that were able to provide a liter of blood flow. 95 in 7 countries, all European, and we add at the very end Canada, because I cannot say without Canadian next to me. Pneumonia was the 80%, in the 80% of the cases, the cause of ARDS. And this just came out from the data analysis. I'm sorry if the slide is not very clear. Here you have the patients treated with a half a liter device and the patients treated with the liter device. Tidal volume, respiratory rate, and minute ventilation at baseline, 6 to 8 hours, 24 to 48 hours. And you see that we were able to decrease tidal volume from 6 to 4, but in patients with low flow, respiratory rate remained the same, and the reduction in minute ventilation was less than what we observed in patients with higher flow, where respiratory rate was actually decreased and the reduction in minute ventilation was much larger. So in terms of protection from ventilator-induced lung injury, the use of higher CO2 extraction devices seems to be more feasible. And as a matter of fact, the number of patients that reached the primary outcome, that was the reduction in tidal volume from 6 to 4 and plateau pressure from 30 to 25, was obtained in the 80% of patients with a higher CO2 extraction devices and only in the 60% of patients treated with the lower extraction devices. That this was obtained with a significant, although small, increase in PEEP, but we obtained an important reduction in driving pressure, that is the difference between plateau and PEEP, that, as you know, is one of the factors that is nowadays have been correlated to outcome. And we obtained this with no significant changes in PCO2, pH, and PF ratio. Survival at 28 days was 73%. We had only 2 serious adverse events, but they were not related to ECHO by an independent data and safety monitoring board. We observed, nevertheless, an important number of device-related mechanical events that are still present with this technology. So we concluded that is feasible, is safe, but more importantly, we use these data using the mathematical model that was proposed by this paper to design the randomized control trial. So we identify criteria to select patients based on dead space, elastance, and delta P that exposed to the super protective ventilatory strategy could provide the real benefit. So we tried to avoid the mistake of the ECMO paper that I presented to you before. And we end up with an estimated screening number of 1,600 patients and a sample size of about 800 patients. So at least we know how we should do the trial. Now, somebody should pay for this trial, but I'm positive we will find it. Partial extracorporeal support in patients with COPD. We have an important number of papers that are showing that in this specific population, the use of patients with COPD, severe respiratory acidosis, and hypercapnia who are failing non-invasive ventilation, that the use of partial extracorporeal support may rescue non-invasive ventilation. And there are at least 3 papers, actually 4, that all show the same result, that use of partial extracorporeal support is able to rescue non-invasive ventilation. And the rescue of non-invasive ventilation in this patient population is associated to an increase in outcome. Now, these are all prospective observational studies that use historical control group. A randomized control trial is going on right now in the United States, and one in Europe will soon start. But I want your attention for 5 minutes on this picture. Now, these are stable patients with COPD, and this is the reason why I didn't give the slide to the slide center, because these are still unpublished data. These are stable COPD patients who are at home with severe hypercapnia and that receive non-invasive ventilation at home every night. In these patients, hypercapnia is not responding anymore to non-invasive ventilation. What pulmonologists do in this case, they call them and they say, let's try non-invasive ventilation here with me in the hospital, and let me see if it's done with me, you get an improvement. They didn't get it, and we tried partial extracorporeal support. And this is the baseline, the value of PCO2. These are the 12 hours of partial extracorporeal support. CO2 was removed, and they were able to obtain a substantial reduction in PCO2. Then the experiment finished, we turned off the pump, and we were expecting to see an immediate jump of PCO2 to the baseline. That was not the case. Look, in this patient, it took 72 hours to get back to the baseline. Now, you are a nephrologist. This is the behavior that was observed at the beginning of the history of dialysis with creatinine. And if this is confirmed, this may provide the basis for the concept of respiratory dialysis. where you treat, like you nephrologists treat in the hospital, in the domiciliary care, in the long-term care, whatever, patients with severe respiratory acidosis for 3 sections a week in order to keep control of hypercapnia. And this is the last set of slides where we can combine partial extracorporeal support and renal replacement therapy that will make the nephrologist happy. Now, you have seen this brilliant review article that connected the lung, the concept of ventilator-induced lung injury with the concepts of acute kidney injury and vice versa. So I don't want to spend time with this. You already saw this paper that showed the relationship between ventilator-induced lung injury and acute renal failure. And you know that nowadays we have systems that allow to treat at the same time acute renal failure by having an hemofilter and to provide CO2 removal by having an oxygenator in Sirius. And we have a number of studies that show the feasibility of this approach. But again, none of these studies had a control group. And this is what I want to present to you, the results of this study. The paper was accepted on the American Journal of Respiratory Critical Care Medicine 2 weeks ago. It's available online. Fanelli is the first author. We had 3 Italian intensive care units which included patients who had, at the same time, acute kidney injury and ARDS. And we treated them with combining renal replacement therapy and CO2 removal in order to allow renal replacement therapy with super protective ventilatory strategy at the same time. And we compared the data with an historical control group that we had that were matched in terms of age, SAPS-2, kidney injury, days of mechanical ventilation, and so on. The study was a pilot study, so we look at the biology. And here you have IL-6 in renal replacement therapy and renal replacement therapy plus partial extracorporeal support. And you see there is a significant difference in terms of pro-inflammatory signal and in terms of tear function. This is the permeability marker of the tubular cells that, as you see, is improved only when patients were treated at the same time with renal replacement therapy and CO2 removal. And the same thing was true in terms of pro-apoptotic signal. So in a way, if ventilator-induced lung injury is influencing the kidney because of inflammation, by providing super protective ventilatory strategy by CO2 removal, we attenuate the pro-inflammatory signal, and this has an effect in terms of attenuation of the pro-apoptotic. But what we also observed was that the creatinine decrease was more significant when CO2 removal was associated with renal replacement therapy, and the days on renal replacement therapy were lower when the patient was treated with a combination of the two. Now, this is my last slide, and I always like to conclude quoting this German philosopher Immanuel Kant that said that everything is morally acceptable if it's available to everyone. Now, as for ECMO and as for partial extracorporeal support, in order to be ethical, we must provide this treatment to everyone. But in order to do that, we need evidence. So we need to do the studies, and we do it to do it in the right way. Thank you very much.
Thank you, Marco, for this very impressive overview about extracorporeal lung support. We will discuss about this at the end of the session, as we have to go on due to time consuming. Next speaker is Dr. Zaccaria Ricci from Italy, and he will speak about artificial organ interaction in the last 20 minutes. Please, Zaccaria.
Thank you very much. don't have the pointer. I want to thank Dr. Ronco for inviting me and for having my presentation after not one but two from Professor Ranieri. I'm just a poor pediatrician, but anyways, I will talk you about artificial organ interaction as soon as we'll have the slides. They should be there. I'll try to keep going. The outline will be to talk about a new concept. So since you've seen that extracorporeal treatments are being used more and more in the overall population of the critically ill patients, both children and adults, here we are.
Okay.
Grazie. Both children and adults are using more and more of these treatments. There is a rationale for combining them and for combining multiple extracorporeal treatments. And as you can see, probably these slides, you've already seen this from Claudio, who is strongly convinced that you can treat patients, multiple organ failures with multiple organ support therapy. So there is a strong rationale for combining many of these treatments and hopefully to have a single platform with all of them connected together. So now we are experiencing a novel concept. There is not a crosstalk between native organs, but it is a crosstalk between artificial organs. That is the topic of my talk. Not everybody is convinced that combining two devices that were conceived for different reasons together could be a good idea, because there are several issues, especially technical issues regarding anticoagulation, hemolysis, inflammation, technical interaction between these two machines. And this is the object of a recent review we've brought together with the speakers of this session, just by trying to remark that yes, you might have some interaction, some negative interaction by using CRRT together with ECMO. For example, you will have the loss of unwanted solids, you might have flow turbulence, you might have circuit pressure, alteration, malfunction of the system, but still you might have benefits from the application of a proactive CRRT system into, for example, an ECMO system by fluid overload control of other mediators, as Professor Ranieri has just showed you. And to convince you about this, I'll show you two different meta-analyses written by the same group, analyzing different concepts of the interaction between CRRT and ECMO. In the first one, they concluded simply that when you apply a CRRT to an ECMO treatment, you end up with a worse outcome in your patient. So if you just read this paper, you are convinced that probably you should refrain from using a supplementary extracorporeal treatment when you are on ECMO. But then they reanalyzed the data by combining mostly the same papers, probably some more, and they realized that when you do the subgroup analysis according to the severity of illness, you realize that the more severe are the patient and the most beneficial is the treatment of CRRT, or at least the mortality is not in favor of ECMO alone, and it gets similar for the two groups. So CRRT is not detrimental, is not